Great.
I'm Brad Power, co-founder and CEO of the Cancer Patient Lab, and this is another session of our weekly session of the Cancer Patient Lab weekly webinar series. Today, we're pleased to have with us Chris Apfel and colleagues to talk to us about his company and the functional testing services that they provide. Let me just do the housekeeping before we get started, which is we have two standard disclaimers. The first is that this is not medical advice. This is just information for you to take to your medical teams. So view this just as information and not medical advice. And secondly, everything that you say will be made public. If you care about having your image or your name or anything you say being made public, then you can not have your image shared on this Zoom. You can put an assumed name and don't say anything. So otherwise, everything you should expect that everything you say will be made public. And so those are two disclaimers. I should just quickly introduce Chris. Chris, as I mentioned, is a scientist and MD by background. He came and saw, and I'm sure he'll tell his personal story, but he saw some experiences with his parents that encouraged him to try and solve some of the problems that patients face. And in particular, he was at UCSF doing certain kinds of work and then decided to launch a startup to provide functional testing services. We've had half a dozen sessions on functional testing, including one with Robert Nagurney of the Nagurney Cancer Institute. And Chris got to know Robert Nagurney in his learning about this area, and he'll probably touch on that as well. But there are a lot of resources that we have. If you're interested in functional testing, I just shared that I got functional testing from Tony Latai's lab at Dana-Farber. I shared those results last week, and you can see what examples of what a functional test can help you make decisions about some of the treatments you may be considering and the ones that look like they might be more effective. So with that, I'll turn it over to Chris. And Chris, generally the format we use is maybe 5 to 10 minutes of introduction, your colleagues, your background, your story, any slides you have. And then we like to reserve the main part for discussion.
Oh,
thank you.
Okay. Then I have to speed up a little bit. Can you see my screen here?
Yes.
Wonderful. And so I also would like to thank you very much, Brad, for the wonderful introduction. I also have Ara Yaganian here on the board on the Zoom call, who is our board member and an advisor, and we are working very closely together. And then we have Rajesh Nityanandan, who is our cancer scientist in our lab and is doing a lot of the hard work with the colleagues and with the team that we have at Sage Medic. Ara, would you like to say a few words to yourself, or should we, or that would probably be great?
Sure, I'm happy to. Good morning, good afternoon, everybody. I'm actually traveling as well. I'm on the West Coast, but I'm thrilled to be here with you all. I was struck by the introductions of many of you on the call. I know the cancer touches just about everybody in some way, shape, or form. And I was fortunate enough to grow up in a home where I was exposed to the science of cancer research literally every day. My dad ran the Children's Cancer Research Labs at Children's Hospital in Boston for 47 years. He actually was the chief scientist at the Jimmy Fund, which is the Dana-Farber Cancer Institute today. And I saw his tireless efforts in trying to eradicate something that was devastating, and great strides, of course, in lessening the impact and improving longevity for young people as they grow older. I met Chris about a year and a half ago, and I had previously been in healthcare, but as a business and strategy and marketing leader. I was the chief marketing officer at One Medical. Then I was in the same role at Sutter Health. And I was struck by how frustrating standard of care is for those who are really trying to do something different and create pharmacotherapies or treatment options that are unique. Chris impressed me because I saw something that was quite genuine. You know, his personal story is remarkable. Both parents succumb to cancer, and father refuses treatment because he sees how badly the treatment went for his mother. And it was an eye-opener. And as opposed to just clenching his fists and moving on, Chris decided to try to solve the problem. And what he's done over the past many years is, through tireless efforts, create an impact project that enables individuals to have, at the time of biopsy, tumor biopsy, a sample brought to the Sage labs in Redwood City, and within a very short period of time, tested against many chemotherapies, and then ensuring that the right chemotherapy treatment is then provided. We look at this and say, wow, how simple is this idea, but how many have tried and so many have failed. I think what Chris is going to describe to you is really how Sage Medic has made this quite unique. So I don't want to go on and on, but I'm thoroughly impressed with Chris, the team, what they've been able to accomplish. I'm a friend of Chris's, but also a board member, and really feel that this passion play of his can change patient outcome across the globe, and he's getting some pretty wild attention as a result.
Thank you very much, Ara. That was a wonderful introduction, and that allows me probably to shorten it a little bit. And my presentation, you have already mentioned a number of important points. What really drove me was the personal experience and the realization that we are, while we often like to believe from major institutions that the future is here now, and the reality is, if one of you is affected, and you have been, you know that we often are living still in the past, and we're not leveraging all the possibilities and technologies that are currently in development. So what we have actually developed is the next generation of an extreme drug resistance assay. And we believe that this will make a huge difference for the millions of cancer patients where often genomic testing doesn't work. And that's one important message that you are probably all aware of, but few others are. And that is that in the majority of cases, patients do not have driver mutations. We all believe that with genomic testing, we call it and say this is precision medicine, but the reality is only 1 out of 4 patients has driver mutations. According to the National Cancer Institute's MATCH trial, that's what Dr. Litai has mentioned in one of his presentations. And then if you actually look how many patients get FDA-approved targeted therapies and how many really benefit from it, we are getting below 10%. So the majority of patients do not have driver mutations nor potential targeted therapies. And that's kind of the devastating state. So most others will get therapies where we actually don't know which therapy is likely to work best. So I was asking, when my dad was diagnosed with lung cancer, I was asking Dr. Yahan from UCSF, who is a key opinion leader and has also co-written the NCCN guidelines. I was asking him, well, why don't we just test it on the tumor instead of trying it out on the patient? And his response was, well, people have tried before, it doesn't work. And one of the arguments was tumor heterogeneity and tumor microenvironment. Probably somewhere, if you put it in vitro, it's different. And it's surprising to me because as an anesthesiologist and intensivist, when somebody has an infection, what we often do is we culture the specimen, culture the bacteria in order to understand which antibiotics are likely to be most effective. We do those in vitro live cell assays, but we don't do it in the oncology space. So I actually took a look myself. I spent about over a year to go through all the papers that have been published in the past to really understand, so why did it not work? And I give you a few examples here that will give you hope. So first of all, there is this concept that if you put something in vitro, it doesn't translate to in vivo. And that is, in this regard, actually not accurate. If you look at the data objectively, this is a paper published by Daniel van Hoff over 30 years ago. They actually were able to grow tumors on agar and then have a control group and then have others growing with different treatments. And they were able to show that, that they have basically negative predictive values of over 90%. So that comes from those numbers, and I don't want to bother you with the statistics, but the negative predictive value, that's the reason why I called it red. So that's actually where the patient doesn't respond. You want to avoid that. And or the specificity, which predicts which patient will not respond, which as well is also therefore red. And sensitivity and positive predictive value are in green, is actually which drugs will work and which patient will be correctly identified that this will work. So 80%. And so the question is, why is it not here now? And one of the reasons is, and that's a problem with whenever you're trying to grow the tumor, growing tumors in vitro is very, very hard. You have heard from Senjin, the organoid models. They usually take 3 to 4 weeks, sometimes 6 weeks. And very often they don't grow at all, because you may not have in the biopsy enough proliferative material. So one of the limitations of those assays were they were accurate if you get a result, but very often you didn't get a result and it took way too long. So this is an example. They only had 30% that it actually took to get a result at that time. And it depends on the tumor type. If we are talking about breast and prostate cancer, the rates are usually in the range of 20%. So it's actually very, very difficult to grow tumors in vitro. I've also looked at many other assays. So it was mentioned that Robert Nagurney was mentioned, and he did, I think, enormous work, has a ton of experience. And he was basically a fellow of Larry Wiesenthal, who developed the DISC assay, and who actually founded Oncotech in the early days, and who is basically one of the key figures in functional profiling. And when I analyzed all the data because I have a quantitative background. I'm still an adjunct professor of epidemiology and biostatistics at UCSF. I actually looked into the data, and I saw in the area under the ROC curve, which is basically the trade-off of sensitivity and specificities for all the assays I could find, all the published papers at that time, I was actually able to see that sensitivity and specificity to predict a tumor response was over 80% on average. So if an oncologist tells you we know it doesn't work, then it's because the oncologist has never dared to look at the data. And that's, to me, frustrating. Because oncologists nowadays do very much adhere to standard of care for good reasons. There is a good reason for standard of care. Standard of care in general improves the average outcome. But there are situations where you actually have to go beyond, especially when standard of care is failing. Now, this one, it only shows a correlation that could be prognostic. What you really want to know is whether you can improve a patient outcome if you are using that information by then selecting a drug that's more effective, and can only know that if you have a comparative effectiveness trial, where you compare two different groups. And so I actually presented this to Robert Nagurney. I showed this also to Larry Wiesenthal. So we actually submitted this then as an abstract to ASCO now almost 10 years ago. And so we know that if a patient gets treated according to what demonstrates sensitivity, or if we are avoiding resistance in this for this patient, the likelihood, if you look here at the data, is that you double your odds to have a tumor response. And that is based on roughly 2,000 patients. And I think the reason why most oncologists, even today, believe that this doesn't work is because if you look at most of the studies, they are underpowered to show a statistical significant difference. So if the error bars of the 95% confidence interval that you see here, if they don't cross the line number 1, the result is statistically significant. All others are statistically not significant, and often the bottom line conclusion is the assay didn't work. And so if you actually look at those papers and you only read the abstracts or the conclusions, you read that most of the papers more or less say, well, we were not able to show it a difference. But there is a difference between the lack of evidence or the evidence for a lack of an effect. And that's kind of confused here. And so when I saw these results, it was very clear to me, yes, it can be done. And so that's actually why we know this can make a huge, huge difference. And what is really needed are clinical trials to convince oncologists to basically that this is an important part on tailoring the cancer therapy to the patient so that the right drug is given to the right patient at the right time. So we conducted a survey and we asked them, would they prescribe or order a test that had those characteristics that I just showed you? And basically everybody said yes. And then I said, even if there were no insurance coverage and you might think that the patient might be able to afford it, then still 2/3 would still say definitely yes, yes, or definitely yes. So it's very clear that there is a need. And then in the survey, we asked, what do you think about chemosensitivity testing? And then some oncologists just stop the survey or just say no, or they say this is a hoax. And it's actually quite interesting how strong the opinions are that to a degree that you really need to have data to get there. What I have therefore suggested to Robert Nagurney and Larry Weisenthal to conduct clinical trials, because clinical trials is one of my expertise. I've published over 100 papers in my field. And so I know how to do that. But they were reluctant basically to randomize patients with either assay-guided therapy or what's considered standard of care, because Robert Nagurney felt, well, standard of care is kind of unethical. But on the other hand, if we don't show it in clinical trials, then at the end of the day, we will never get traction so that it will be universally accepted. And that's when I started to realize we need to develop our own assay. The assay that Robert Nagurney developed is quite dated. The biology is still true, but there are a lot of things that could have been, or I believe we have improved. And so we have now developed an assay that can actually go beyond what was possible before. So we can look at tumor resistance, and we know from our predicate assay here that when a patient's tumor does not respond ex vivo to the therapy, then at supraphysiological doses, then it can also not respond in a patient. So that's generally known. And so we actually dose the drugs, the microtumors that we are creating at various doses, and therefore we can actually also use supraphysiological doses, and we can actually see that if the patient's tumor is still viable, that this cannot work. We also know that taking the tumor as a whole, the whole is more than the sum of its parts. It's more than just the DNA. It's more than the RNA or a metabolic pathway. We actually, and especially when we are not just taking single cells, but we also can consider the extracellular matrix and cell-cell interaction, and therefore mimic the microenvironment, that we have basically a fairly good surrogate for how this tumor would respond in the patient. And that could also be used for drug development, which was that slide referring to. So our goal was really, we need to be able to have actionable results from a fresh cancer biopsy within 1 week or 10 days. And that's kind of the key message. We need to make sure we get this for virtually every patient. It can't be that we need to wait for weeks or months until the tumor has grown and then finding out it hasn't grown, or we should actually mimic this to as close as possible to the patient's body and not just look at the single cells. So we can now create live 3D microtumors of the patient's biopsy within just a day that retain the microenvironment and heterogeneity of the biopsy so that we can test multiple drugs to identify the most effective treatment within just 1 week. And our projection is that we can double the tumor response, significantly improve the free survival, progression-free survival, and improve quality of life, which might also be reducing costs. So we are very bullish on believing that we can do at least that, because our meta-analysis already shows that previous assays have such a treatment effect, and our assay, which is now much more advanced than has previously been on the market, is therefore should do at least that. This gives you a rough idea on how we do it. We maximize the yield of tumor fragments that have the original cell-cell interactions, the original matrix and tumor microenvironment, and that is basically is in a suspension, and then we have an aggregation step where within 1 day we have the formation of these microtumors that basically where each of the wells reflect the tumor biology and the microenvironment and the heterogeneity of the biopsy sample within each well. And then we can have different readouts. One of the readout is looking at with a confocal microscope at how many cells are dead or alive, which you can see here. You can see a tumor that is actually treated with is a control group, and then you see here one that is completely destroyed by a fully effective drug. And what we do is we actually do full dose response curves. It's actually very easy just to pick one dose and be wrong. When it comes to patient lives, it's really important that we know the data points are reliable and reproducible. We've worked a lot on reproducibility, also are working with quite a number of replicates. And this is an example of a multiple myeloma patient where we can see here with Velcade, bortezomib, you can see that it reduces the viability at a certain concentration. And as opposed to lenalidomide, like Revlimid, or metformin, which somebody else also wanted to ask us to test, those drugs are not effective, as opposed to those that can significantly reduce the viability of those multiple myeloma cells in the tumor. And we then aggregate those results to a bar chart so that oncologists can directly actually come up with a conclusion and have actionable information. Because we are also going to extreme drug concentrations that could not be tolerated by a patient, physiological, we are very certain about the prediction of tumor resistance. We believe that our prediction in our prospective study that we are planning will be above 90%, probably enough above 95%, that we can predict tumor resistance in patients. And then we also have information on the sensitivity, but the sensitivity information that requires calibration. So whether bortezomib is really more effective than carfilzomib, I don't think one can actually make that claim, but at least one has an idea on which drugs are likely to be most effective. So this was done for Dr. Konieczny, who was a pediatrician himself, and he really appreciated that to have that information that otherwise would not be possible. We have recently, this is a result from where we actually went beyond our call of duty beyond just testing standard of care drugs, because the mother of the patient really wanted us to try whatever is potentially available and possible. So we, on the one hand side, we tested drugs that are used for rhabdomyosarcoma and looked at the sensitivity and resistance. We also tested repurposed drugs. So, for example, integrative oncologists often talk about lovastatin, disulfiram, losartan, celecoxib, and depending on the patient, they may actually have some effectiveness. We were very, very surprised to see that lovastatin and disulfiram had those cytotoxic activities at physiological concentrations. So we were quite impressed with that. We are not suggesting to substitute this, but this was on a lung metastasis of this patient, and so we really need to find the best possible treatment and combinations. And so what's here clear is doxorubicin and cyclophosphamide actually showed the highest effectiveness, and that's actually what this patient is now going to get. And so that's actually what SAGE can do in order to make sure that the patient is getting the best possible treatment and is not hurt by treatments that we know cannot work ahead of time. So, for example, ifosfamide, that is down here, that is not effective at all, and it's often also given in combinations. That would only lead to side effects for this patient that would be completely unnecessary. One important part is for us also reproducibility, and we are very proud to say that even if we have shipment delays, etc., because this is fresh tissue, there's always a concern: is this still valid? And we know that our assays are very, very robust. We have actually, during the times of COVID, spent a lot of time in making sure we have all the SOPs in place. Establishing a clear lab is actually non-trivial. If you're not coming out of a academic center or that already has a pathology lab or a clear lab running there. And we are very proud that we are now a California registered, clear registered, and CMS accredited lab that can actually report patient results. So with that, I would like to come to a conclusion. This would not have been possible with a wonderful team, including Ara Yaganian and including my wife, Dr. Brigitte Apfel, who really has supported me throughout the years in getting this off the ground. So we actually invested most of our savings in getting this started, developing the IP, have raised some more angel capital. We have not been as lucky yet to get the big venture capital funding like other companies that have a more cooler technology out of a major institution, because we actually have developed the technology all on our own and all the IP. But we are very proud that we actually have such a wonderful team that has made this possible. Without this would actually not be possible. So what we can do with our SAGE direct test that we now call the SAGE Oncotest is we can use it for non-resectable or recurrent solid tumors that have usually exhausted first and second line treatments. And there are a number of examples, from ovarian cancer to glioblastoma, late stage prostate or breast cancer patients, or colorectal and pancreatic patients as well. So there is a lot that we can do here. The next steps are to collaborate on pilot studies or tissue donation studies, and if patients really need these results, we can actually run those results anytime. With that, I would like to open this for discussion.
Thank you, Chris. The way we like to do this is to have people use the raise hand feature, and then I'll call on and moderate the questions for you. Also, if you want, you can put things in the chat. We can monitor that as well. I'll just get started to put things in context, Chris. It seems you have a better, more modern approach and a better lab pipeline to functional testing than, as you said, maybe some older technologies. But I would assume that you would still have the same issues, that a patient needs fresh tissue, because a lot of our patients, are in remission or they have bone mets where it's hard to get tissue. And then the other thing is that I assume this is largely for chemo or targeted therapies. I guess historically functional testing was used for chemosensitivity. Those would be either chemo or targeted therapies are the main therapies you would be testing, which would leave out things like immunotherapies. So can you speak to those two? What's the input source that you need to run your test? And then second, what kinds of treatments might it be applied to?
Yeah, so important questions. Number one, yes, we need fresh tissue. It doesn't work with paraffin fixed tissue or if it's already in formalin, which is basically the standard nowadays. If a tissue is removed from it at surgery, it's thrown into formalin, then the tumor is dead, and then you cannot do functional testing. That is actually true, and the reason why functional testing has this power to make a prediction on what would work is because it's alive. So you need to have live tissue. One of the advantages of our technology is that we need very little tissue. So we actually have been able to obtain also tumors sample and work with samples from ascites or from a pleural effusion. And so we can actually get reproducible results from those patients as well. So late stage patients sometimes have those situations that need to be drained. In that case, you don't need an additional biopsy. And we have refined our technique that we can also work with core needle biopsies, provided that they have a high tumor content. So if we have a core needle biopsy, that is another possibility if this is in particular, if this is a high-grade tumor. And usually what makes most sense is if the patient is scheduled for surgery, it's important that we get informed ahead of time, ideally at least a week, but we actually need at least 2 days to provide them with the shipment kits so that we can get the specimen. In gyn-onc, it's very important. Patients are scheduled for ovarian cancer. The ovarian cancer oncologists, gyn-onc surgeons are very open to that because they know the situation that they have access to the tissue, but they often also do the chemotherapy or target therapies, let's say PARP inhibitors for patients with BRCA mutations. They also do the chemo or target therapies on the patients later on. And so they therefore know how important it is to have it. And so they are very happy to provide the samples to us. Immunotherapy, we are currently not testing. I think I'm very skeptical if somebody makes a claim in that regard. That is still an area that needs development. But let's keep in mind, in immunotherapy, only 1 out of 5 patients are responding to it. No matter how much you might test, I mean, it would be nice to know, but most patients do not respond to immunotherapy.
Okay. We'll go to Roger next, but let me follow up with Alan Morris has a question in the chat, which is similar to the point I mentioned. What if someone has their cancer is active, but it's in the bone? Is there a way to access your test with tissue from the bone?
Yes, we can access tissue from the bone, from a bone biopsy. We have done bone marrow biopsies, which of course is slightly different. We can also do soft tissue sarcomas. We haven't done osteosarcomas, and there it could actually interfere. If it's a real tumor from the bone that usually is not calcified, and prostate is a typical example for that, that should not be a problem, but we have not tested prostate tissues from the bone. So just as a caveat, there is no reason why it shouldn't work. What really matters is actually how aggressive the tumor is. If you have an aggressive tumor, and most bone tissues, bone tumors are actually aggressive, you should get at least some of those options that can make a huge difference to you.
Thank you. Roger, and just to introduce it, Roger's nearby you in Palo Alto. He's probably just down the street. And he's a pancreatic cancer survivor. Roger.
Yeah, hi, thanks. Yeah, we had talked before. It's good to see you again. And I might have miss this. I have 3 questions. And I just want to make sure you have to have live cancer cells to do this, right? They can't be frozen or on a slide. So it has to happen fairly immediately after
Right.
a biopsy or surgery. Okay. And, I've come to find out that this tumor tissue is like really precious, especially in pancreatic because it tends not to have as many cancer cells. Are these samples, I mean, is it a large amount that you need? Is it, is a patient going to have to make a choice between using their tissue for this or something else, or is it relatively small amount? And then finally, what are the prospects that you might be able to do this with a liquid biopsy or a blood test at some point in the future?
That's hard with the liquid biopsies. Liquid biopsies are primarily focused on cell-free DNAs, and those have not shown to be predictive. They can only identify existing mutations, and often they don't correlate with the tissue biopsy very well. So that's basically an issue with liquid biopsies. There are some efforts also from a German group that is looking at circulating tumor cells, and that is a possibility to grow those if you can find them. But they are exceptionally rare, and it would take months to likely grow organoids. So if there is somebody who isolates those single cells from circulating tumor cells, or those circulating tumor cells, and is able to grow them to organoids, then an approach like Sengen has would be the most appropriate one.
And the question was, how much tissue do you need also?
Right. So we need about 100 milligrams to test the main, let's say, 4 to 6 main drugs on it. And so if you would go in a pancreatic cancer case, if you would go through the gastric route and do a fine needle biopsy, that would likely not be enough. And often they don't have any tissue at all. There are often many attempts to get actually to the tumor tissue. What is in the, and I'm not an oncologist, but what is possible in pancreatic cases is to do a laparoscopic staging and then get specimen on laparoscopic staging. And that would be half a gram would be plenty. We could test quite a number of drugs. And the advantage would be to be able to see, is it gemcitabine? Is it FOLFIRINOX? Is it nab-paclitaxel? There are different treatment options, even in first-line treatment for pancreatic cancers. And so therefore, having an exploratory laparoscopy, even if it's not operable at this point, in order to get it tested so that one can actually hopefully convert this tumor from an inoperable one to an operable tumor, and then have a surgery in order to overcome that.
Thank you. Next up is Amit.
Thanks, Brian. Thanks, Dr. Chris. Very interesting conversation. I'm a prostate cancer patient with all bone mets. So as you're hearing from many other comments, getting a tissue is really, really hard from bones, and bone biopsies are not that simple and easy. My question is, if I am able to get a bone tissue, and you do some testing on that, is it possible to keep that tissue alive and keep my biological twin going in your lab for testing of multiple drug resistances over periods of time? Let's say, you said, this chemotherapy is going to work, or this drug is going to work. 9 months later, things change. Is it possible to keep a biological twin of my tumor and microenvironment going in the lab that can continuously be used as opposed to regular new tissue?
Yeah, so our advantage is that we can actually, and that's a good question, we can actually freeze it and thaw it again. During this freezing and thawing conversion, there is some cells won't make it. In principle, you get a certain proportion of cells that actually you can revive, and then you can do testing on that, and you get very similar results. One of the reasons why it makes sense to access the tissue, and I'm coming back to the ovarian cancer case, Dr. Frühauf has actually shown that if you have tumor resistance in the first place on drug A, B, C, D, E, you will also have it later on, a year later, or 9 months later, 1.5 years later, on drugs A, B, C, D, E. And so the tumor resistance is a relatively constant signal. The sensitivity is a signal that may change. So because tumors under therapy develop also their own resistance. And so that's then harder to predict, but when we would at least know what the resistant part is.
Okay. So just as a follow-up, right? So suppose I'm based on your study, you say carboplatin will work for me. I'm, given 6 doses of carboplatin. You can kind of maintain that in your lab and expose my tissue to 6 doses of carboplatin so that, 9 months later down the line, my tissue is a close reflection of my actual body and how my body has evolved.
That's a smart question. We haven't done it yet. We could. It would be a separate project, and it's really R&D. It's not. It would be outside of what would be clear approved standard of care, right? So one would need to be aware of this is a experimental setup, and we don't have validation for that, because the question is also whether the tumor is changing in the same way
Right.
over that period of time as it would be in your body.
Right. Okay. So that hasn't been tried yet. Okay. Thank you.
That was going to be my question. Sorry, just going to chime in here. Didn't raise my hand. I would imagine that it would be difficult to mimic the dosing ex vivo versus in vitro.
Yes.
I'm sure there's a lot of complicating factors, but that seems to be like probably one of the top ones.
So good point. That's one of the reasons why we calibrate our dose response curves in order to compare the drugs somehow by the Cmax concentration that you can have in the plasma. But even that is a crude approach, because the Cmax or the plasma concentration have different curves on how fast they get redistributed or metabolized. And so even that comparison has limitations. There is also another interesting thing that I wasn't aware of for a long period of time. If you look at plasma concentrations that patients have, same dosing, sometimes they vary plus minus 200, 300%. One patient has a 300% higher concentration than the other one. And it's same, they get the same dose. They have different distribution, different body fat, different body mass index, whatever there is. Women sometimes have different, in their liver, different metabolic pathways than men. So dosing is very, very difficult. And the standard of care in clinical practice is usually you start off with a very high dose. And with this very high dose, if the patient can tolerate it, fine. If the patient can't, you dial it back because of the side effects. That's brutal. I'm in discussion with a very senior key opinion leader to devise a study where we use low dose combination treatments of those drugs that show sensitivity in our lab, and they will then be combined at a dose that is a fraction of the dose that's usually given. So let's say if you actually do half the dose, you have a fraction of the side effects, even if you have a combination of drugs. And so we can, it's hard to say which dose is necessary. And I'm very optimistic on this approach to use low dose combination therapies of those drugs to which the tumor is sensitive to.
We have a whole session on personalized dosing. Brian, did you get it? Did you have any other questions, or are you good?
Yeah, no, I do have some more questions. So maybe I'll just stay in this lane here. The dosing is a really interesting component of getting these drugs. There seems to be this proclivity to go for sort of the kill shot, right? But the kill shots rarely work, right? And so what happens is that patients, particularly patients like prostate cancer patients who can live with the disease, even in an advanced state for quite a long time, get exposed to a lot of therapies. And then you just get a heterogeneous mess of cancer cells, and they become really difficult to treat. So when you think about the recommended drugs, are you also thinking about dosing? Are you factoring in how adaptive therapy, for example, which I think that we're pretty big proponents of, particularly in the prostate cancer setting? Are you thinking about that, or are you thinking about the kill shot?
Oh, so I had, I had also other family members being affected by cancer. I know what this kill shot does to patients. One of my best research fellows at UCSF was a BRCA1 patient, and she was last year diagnosed with, had a prophylactic hysterectomy and was diagnosed with stage 4 ovarian. And the neuropathy that has developed is not nice. There are enormous side effects. There are many high dosages can also be lethal, right? You can have a bone marrow suppression that leads to a sepsis, and it's going very, very quickly. And so the whole trying to dose it to the maximum dose is not what I would favor. I'm more on your end. And one of the reasons is if you look at the dose response curves, they're actually pretty flat. And if you, so that means if you actually have only half the dose, you may have 10% difference in how many cells survived. So that's with half the dose. And we have seen, Rajesh, perhaps you want to mention that we have seen some effects on combination treatments, on synergies. Sometimes they're completely independent, and sometimes they potentiate one another. And we can see this because we are running those dose response curves. And so I'm a big fan on dosing it as low as we can, and then use the combination of the drugs that are most effective. And I do, interestingly, it makes sense also to test the combinations, because you may have one drug that has a good effectiveness, you have another drug that has a good effectiveness, but if you combine them, it's not better than if you give just one. So we see this in our lab, and so finding the right combination, and therefore reducing the dose, in my mind, is promising, but one needs to be aware that we need to have, like Dr. Leyland Jones is a person I'm in communication with at the Avara Cancer Center. He is a leading oncologist. He could actually, he is one of those individuals who believes in low dose combination therapy.
Great. I've got a couple more questions, but I'm going to I see we're short on time, so I'll let some other folks jump in. It looks like Jeff's got his hand raised.
I just have a quick input if you guys don't mind, but Nick Shork has really been the key guy for doing the working with Avera on their dosing. So he did a lot with setting up that trial. So he's very familiar with it. So you've already got someone that's in the group that knows that stuff very well.
Can you repeat your question again?
No, I was just saying, when you mentioned the Avera trial and doing their precision medicine, Nick Shork actually helped set up that trial, and Nick's part of this group. So they've got a good contact in that group already.
Okay.
And I've got a long-term relationship with Avera as well, so I can get you in the right people there.
Okay.
Hi,
Thank you.
so Jeff here. One of my questions is how similar or dissimilar are, say for prostate cancer, a bone tumor or a soft tissue tumor? Are you going to see more similarity in terms of drug response, or are two samples better, or even from different bone metastatic sites? Is there enough similarity so that one sample will be beneficial or mostly beneficial?
Yeah, so that comes to the question of tumor heterogeneity.
Mm-hmm.
And early stage tumors are usually monoclonal. So if you can get it at stage 1 or stage 2, you may actually have a higher chance of eradicating it. If you think of adjuvant therapy that's given for patients that have just nodal disease, and you have an effective therapy, you sometimes have a separation of the survival curves of about 20%. That means 1 out of 5 patients will actually have long-term benefit from this. As soon as we are talking about a later stage disease, we actually have different tumor clones that may or may not have different sensitivity profiles, and therefore you sometimes see that the tumor is shrinking on one part and is growing on another part. And that's actually what brings this awareness on tumor heterogeneity, which makes it so difficult to be precision medicine, because you can't just give this drug to those cells and this drug to that cell. You have to actually give it systemically. And so that's another argument for low dose combination therapy of those drugs that are sensitive to it. So if you are talking about a late stage tumor, it would be good to know which are the combinations and then test those combinations as well in order to know there is synergy between combining those drugs. Does it answer your question?
Yeah, that does. Thank you.
Coming back to the one example on are they different on the different spots? We have looked at some colon cancer patients that have actually, where we had the primary and the one that metastasized to the liver, and the sensitivity profile was basically very similar.
Are many
Glenn Saban has a number of questions in the chat, so go, Glenn.
Yeah, are many oncologists prescribing based on what your report informs?
So that's an important question. Oncologists in general are under significant pressure to practice within standard of care. It is one question is insurance coverage. Oncologists often, even within standard of care, have difficulties with getting coverage. And so because of that, they're reluctant to go with something that's not covered by insurance. It's hurdle number 1. Hurdle number 2 is there's always a concern on liability that they feel restricted. So for example, with this pediatric patient, especially because pediatric patients are also a vulnerable population, getting beyond standard of care, what's not mentioned in the guidelines, is really difficult. So we actually, in order to maximize the benefit for patients in an early stage, we often say, we just report the standard guidelines choices, and there are often, especially at a certain stage, there are, let's say, 5 to 10 to 12 choices, and that allows the oncologist then to treat and choose that. if you go outside of that, you need to find an oncologist who is comfortable with that, and the patient should know this ahead of time. If we are testing a drug that is, let's say, a repurposed drug, one would actually have to make sure that the oncologist is also comfortable with that.
So if you have access, if the patient's able to get access, let's say through, compassionate use, as one example, and so the drug and the reimbursement and everything related to that is a non-issue. Do you have a small group of community and or academic oncologists that have heretofore delivered these drugs and combinations that have been informed by the report for patients?
I know that Dr. Leyland Jones is open to that, but the number of oncologists are really limited. I was actually thinking whether I should approach Dr. Nagurny again on whether we should do that and whether he would be open to it. Because, but actually, when we developed our assay and I showed him what we have done, I offered him to collaborate. We could even do a cross-validation, and he, for whatever reason, said, "Oh no, well then you drive us out of business." That's what the message was. His concern was. That's how I felt about that. It came across to me, but
so if you had a network of open-minded personalized oncology experts willing to prescribe off-label, which is already about 40% of the anti-cancer agents anyway, that would be useful for you, correct?
Very useful.
And then what about as far as you're pre-revenue, right?
We have started to offer our assay commercially, and what we do is our MSRP is 4,800, and we give a discount for oncologists who are working with us collaboratively, and where we get patient outcome data, because that's actually what's important to us to really demonstrate that.
So if all these cases that moved forward and utilized these agents and combinations thereof, through the management of a oncologist, would it be useful for you then to have all these cases in a high quality registry and perhaps a learning health system overlaid on that?
Yes.
Okay. And then how close are you to like a category 3, like CPT? Are you nowhere near like a category 3 just to have the code?
I believe this depends on the health economics. I do think that insurance companies are not only looking for an improved outcome, they are actually looking for also cost savings in order to get a CPT code. That's kind of my sense. And so that will need a separate study on getting a CPT code.
Yeah. Are you willing to sell directly to consumers, patients without a order? Since, as long as they're working with an oncologist, that they're communicating and bringing them the results of the report?
We would like the oncologist to be on board for this to be of the benefit of the patient.
Yeah, that's the only way it'll be delivered.
Yes.
Otherwise, it's just information that may or may not be acted on.
Right. And so the patient himself cannot order the test. The patient needs a physician. Technically, if the patient were in California, I could do it myself, but we haven't gone down that path.
Yeah, I think there will be options for you to explore.
Yeah, and there are and it can be any physician, right? So it could be the general practitioner, it could be the concierge physician. So it doesn't have to be the oncologist. Sometimes the surgeons say, "Why not? Let's move forward with that."
Right. What kind of validation data are you developing now
So we do think that the first step would be the case series to demonstrate and correlate the sensitivity and resistance results with the patient tumor response.
So combinations of case reports across like pan cancer?
Right.
Uh-huh. And have you already started developing these?
We have some protocols in the pipeline.
Okay, very good. Yeah, really appreciate you guys presenting today.
Tell me about your background. What triggered your curiosity?
Well, we're working on developing an end-to-end kind of service with a hybrid nonprofit and for-profit that would essentially addresses all of this unmet need and rate limiting factors, several of which we've discussed. And so we're actively kind of developing this, and a N of 1 physicians network is just one piece of that. You know, so maybe Brad can or Ryan can connect us, and we can have a conversation that digs into that, since we're beyond the time, and I'm cognizant of that.
Thank you, Glenn. Let me just piggyback on that. Chris, how's your time? Can you go a few more minutes, or should we?
I can. Let me just double check on my calendar. I think I can.
But I actually can't, because I'm late for my next thing.
No, we'll make a connection offline with Glenn.
Okay.
And Chris.
All right.
We'll do that.
Yeah.
Thank you.
I have another 15 minutes.
Okay. I know Ahmed had another question. I personally wanted to ask one more, and then I'll stop the recording. You flashed an experience you had with that rhabdomyosarcoma patient, and you may know that we ran a hackathon for another rhabdomyosarcoma patient. So what I recall,
I didn't know.
yeah. So what I recall from that is that they respond to the chemo, and then it fails, and it's a number of cycles. But every time, like, the chemo works, and there are no evidence of disease, and then the cancer comes back. So it's a kind of an endless cycle, unfortunately. Is there anything in your testing that can look at the durability of the response, so that, like you had that example, and it was like, these look like, this combination looks like 97%, but is there anything that is a prediction that would look at durability?
That's a tough one. That's a tough one. I think the key would be to trying to eradicate it really as much as possible, and then get it below the detection level. But I'm not sure whether that pattern is known for, I would like to say, high-grade tumors, that they tend to be more sensitive to a drug. They develop then a resistance, but because they're high grade, they may then still have sensitivity to other drugs until they develop resistance there. That's not, I'm not sure whether that's typical for rhabdomyosarcoma.
All I remember is there's about a 30%, the standard of care is chemo, and there's about a 30% success rate. So,
right. And that's not good.
That's not good.
And I think we can do much better than that.
Okay. Ahmed, you get the last question. Do you still have a question?
Yeah. Travera presented to us a few months back, and they are kind of, seem to be in similar space. I'm sure you know them better than we do. Can you help understand the difference between what you're doing versus what Travera is offering?
Yeah, so that's interesting. Travera, as far as I understand, is they're looking at single cells, so not at the tumor as a whole. And so they don't have the tumor microenvironment and the three-dimensionality that is nowadays very much emphasized. That's number one. Number two, they make a claim to measure or be able to detect effects in a very short period of time, which may be true for typical cytotoxic drugs that are cytotoxic, irrespective even of replication. But there are many other drugs that just need days and weeks until they become effective in a patient body. And so the concept to be able to measure within a few hours or within a day the effectiveness of a wide range of drugs, that's kind of interesting. That needs to be shown. What we do know is we have looked at how long do we need exposure until the cells start to die. And what we have seen is we have done 1 day, 2 days, 3 days, 4 days, and I think beyond that, 5 days. And we see that for most of the drugs, for 90% of the drugs, they need at least 2 days, if not 3 days, to really see a treatment effect. Usually when a cell is starting to die and is entering apoptosis, that can be, for example, measured with this BH3 assay that Tony Letai has developed. Once they enter this cascade, they usually die within a few hours. So if a cell decides to die, that decision, you will have a treatment effect relatively quickly within a few hours. And so that's generally accepted. And we see in our lab that you need at least 2 days, usually 3 days, to see that effect in a reliable fashion.
So going back to your first point about that they are focused on single cell versus the tumor microenvironment, as a patient, I mean, what I understand is it's the tissue sample that they are getting. So they're getting exactly the same thing that I would be sending to you or to them. Are you saying that they are isolating and working only on a
Right.
very small part of it? I see.
Right. So they're isolating the individual tumor cells or cells, and then they're measuring the effect on the individual cells, irrespective of the tumor microenvironment, irrespective of the extracellular matrix, etc.